Well, thank you very much for the opportunity to be a part of the ACURE conference again this year. It's really a treat for me. So yes, I'll be talking about how left ventricular unloading can reduce right ventricular preload, and specifically in patients with decompensated heart failure and associated cardiogenic shock. So as we've covered quite extensively today, decompensated heart failure and cardiogenic shock is common. I think there are a couple things that I'll highlight. One is that the proportion of patients with cardiogenic shock and heart failure is increasing. And unfortunately, mortality rates have remained quite devastating over the last several decades. And we know that right ventricular dysfunction, when it occurs, is associated with worse survival. So what are our goals as we care for these patients? Certainly we want to support the systemic circulation, but we also want to offer extensive decongestion. And ultimately our goal is to minimize myocardial workload in this process. So as we think about these patients with refractory cardiogenic shock, stage E, how can we accomplish these goals? So this is where ventricular unloading has really emerged as a method to offer myocardial protection. And I think a key question is how can we use maximal LV unloading to improve RV performance in decompensated heart failure? Most of our understanding in this field is limited to the computational domain, and here are some computational predictions of what might happen. So on the left, you can see the left ventricular response, which we've talked about today. After decompensated heart failure, we have a really nice unloading with this adoption of this triangular shape pressure volume loop. And it's predicted in this model that in the RV on the right-hand side that there's reduction in RV pressures and volumes that's associated with maximal LV unloading. But whether this bears out in patients with decompensated heart failure is really unknown. So to examine this question, we hypothesized that maximal transvalvular LV unloading would decrease right ventricular pressures and even pressure volume area in patients with decompensated heart failure and associated cardiogenic shock. To examine this hypothesis, we turned to a clinical case series. So far, we've enrolled 6 patients with decompensated heart failure and refractory cardiogenic shock. They all underwent Impella 5.5 implantation via axillary cut down and 10 millimeter graft. And this was done as a bridge to transplant or durable device therapy. We did invasive hemodynamics of biventricular function in these patients. We looked at arterial tracings, PA catheter tracings, and biventricular pressure volume loops. We did this at 2 time points, first at baseline and then acutely after Impella 5.5 activation, so within 5 to 15 minutes on support. And we did an analysis based on the aggregate patient cohort as well as on a per patient basis. So here are some baseline results for the cohort. You can see that on the top right, they're relatively young, predominantly male, and required on average 3 vasoactive agents, including 1 or 2 antidepressants on average. 2 of the patients required inhaled pulmonary vasodilators for refractory cardiogenic shock. All patients had a severely reduced ejection fraction with dilated LVs on average. In terms of baseline hemodynamics on the bottom right, you can see there's a significant right and left-sided congestion with elevated right atrial and left ventricular end diastolic pressures with an increased systemic and pulmonary vascular resistance. These patients were incredibly sick. So let's turn to our results. So this is left ventricular end diastolic pressure and right ventricular end diastolic pressure at baseline and after Impella 5.5 activation. And you can see that amongst the cohort, there was a statistically significant reduction in filling pressures, both in the LV and in the RV, in the acute setting after Impella 5.5 activation. And this suggested to us that those patients with decompensated heart failure and cardiogenic shock with just LV unloading can have a reduction in biventricular filling pressures. Turning to myocardial workload, we looked at the pressure volume area, both in the LV and the RV. All patients on the left had a significant reduction in left ventricular pressure volume area after Impella 5.5 activation. On the right, you can see when we turn to the RV, there was a more heterogeneous response. 4 of the 6 patients had a significant reduction in right ventricular pressure volume area. 1 patient had no change in their RV PVA, and 1 patient actually had an increase and right ventricular pressure volume area in the acute setting. So to demonstrate these results, I want to turn to the pressure volume domain and show you some representative hemodynamics. So here I'm showing a patient case with left ventricular and right ventricular pressure volume loops at baseline and after Impella activation. And in this case, you can see that this patient had a significant reduction in pressures and volumes, both on the LV side and on the RV side. And this was the most common phenotype that we observed in our study in 4 out of the 6 patients, whereby there was a coupled reduction in left and right ventricular pressures, volumes, and pressure volume area. Now, turning to those patients with a differential response, here's one of those patients that had increase in right ventricular pressure volume area. So on the left, you can see in red, we have a really nice reduction in LV pressures and volumes and pressure volume area, whereby on the right, we actually have an incredible rightward shift as the RV is able to distend and accommodate additional volume after LV unloading. This occurred in one patient, and I mentioned the other patient had no change in right ventricular pressure volume area afterwards. And I found it interesting that both of these patients required inhaled pulmonary vasodilators for refractory RV failure. All of the patients tolerated the procedure well in the acute setting, and at the end of the study, before even leaving the catheterization laboratory, 3 patients had 1 or 2 vasoactive agents already weaned off. So to conclude, we identified acute hemodynamic responses to Impella 5.5 activation in patients with decompensated heart failure-associated cardiogenic shock. All patients had a reduction in biventricular filling pressures, as well as a reduction in left ventricular pressure volume area. There was indeed a variable RV response, but we did observe RV pressure volume area reduction in select patients. And these findings suggest that maximal LV unloading may improve biventricular performance in decompensated shock patients. And it may well be in those patients with refractory RV failure that we may need additional devices or time on support to develop additional benefit. Certainly, this was a small study limited to our single center, and additional enrollment is ongoing. I think it will be interesting to include more patients with refractory RV failure and ultimately identify those patients who require biventricular support. So with that, I want to thank you very much to the ACure team for inviting me. Thank you to Dr. Kapoor and the incredible lab team that I get to work with there, as well as all of our collaborators and funders. Thank you very much.